If you're here for Dr. Reto Nieger, you can skip the Danish intro. It's a couple of minutes, and you will find the interview there. Succes i veterinær praksis, podcast nummer 179. Jeg har haft den her podcast-episode på ønskelisten i lang tid, og jeg har haft Reto i tankerne til episoden i lige så lang tid, og derfor er det mig en stor glæde og fornøjelse at præsentere dagens interview, og der er virkelig noget at komme efter. Vi går helt systematisk frem efter, hvordan at han foreslår, at vi tilgår en opkastpatient. Og vi snakker lidt om, hvordan vi behandler på de milde og de mellemsvære og de besværlige cases. Og så tager vi 2 cases fra klinikken til sidst, sådan at vi ligesom kan komme omkring, hvordan han tænker på de her cases. Og du kan jo gætte med og se, om din tankegang var cirka den samme, og om du kan komme med nogle foreslåede diagnoser. Men det er til sidst i podcasten. Links og noter finder du som sædvanligt over på hjemmesiden på sivp.dk/179, fordi det her er episode 179. Vi har også lavet sådan nogle PDF-ark, der kan hjælpe dig, en slags cheat-sheets, om du vil, der kan hjælpe dig med de her GI-patienter. Der er både lidt om diarré, og så det her om opkast. Og det finder du også over på hjemmesiden. Du får det ved at tilmelde dig nyhedsbrevet, og jeg lover, at jeg ikke spammer, men jeg fortæller dig om sådan nogle online-kurser og nye podcast-episoder af den slags, så du kan melde dig fra med et enkelt klik i hver mail. Det er en gratis service, du kan tilmelde dig over på hjemmesiden, og så får du oven i købet de her PDF-ark. sivp.dk/179, og så over til interviewet med Reto. Hi Reto, and welcome to the podcast.
Hello, Søren. Thanks for inviting me.
Some of my listeners will know you because you have given presentations here in Denmark before. But for those who don't know you, can you please give us a clip notes version of what's important that people know about you before we start?
Sure. Yes, I'm a Swiss veterinary degree from Switzerland in a long time ago. And I've been practicing in many countries, in the US, in the UK, and now I'm living in Germany, where I've been now for over 20 years. I used to be a professor at the university and then went to the largest small animal clinic in Germany called Hofheim, where I worked for 3 years. And now for the last a bit more than 4 years, I've been country medical director with IVC Evidensia. I am a diplomat in internal medicine of the American College. And my main interest basically is everything in internal medicine, from gastroenterology, nephrology, endocrinology. So there is no really main interest.
But we will have to try to keep a narrow focus on vomiting dog today. So hopefully I will manage to keep us somewhat on track. Knowing myself, this can sometimes take a tangent, but let's start there and see where that takes us. So I like usually to follow the patient through the clinic. So in my world, this starts by the owner phoning us, telling us that her dog has been visiting, let's say 2, 3, 4, 5 times, but seems somewhat okay otherwise. At what point would you recommend a first opinion vet like me to call the dog in for an examination?
Definitely when the vomiting is happening more frequently, when the animal is showing more than just vomiting. I always say if the animal is sick and vomiting or healthy and vomiting. And what I consider healthy and vomiting, I mean, you can't be healthy and vomiting. Of course, that doesn't really work. But if the animal is still eating and happy and running around and wagging its tail and everything is fine, if the owner can also look at the mucous membranes and that looks normal, if the animal has no diarrhea, if everything else is fine, and it's just vomiting, then, and that has been ongoing for 1-2 days, then often it might not be needed to be seen. However, I know we all need to earn money. It might be needed to see also a dog like that. But overall, if more than just vomiting is happening, if the owner is able to take the temperature in the dog and that's low or high, if other clinical signs such as I said diarrhea, or if the animal has some discharge, if the animal has bloody vomiting, especially if there is if the animal has bloody diarrhea, anything like that, lethargy, etc., that all definitely needs to be seen.
Good. So I call the dog in, and I will try not to jump straight into the physical examination, but try to have a thorough first. And I'm sort of confident in take a thorough history, but is there something in particular that you are looking for or asking for?
I definitely in the history would like to try to differentiate between vomiting and regurgitation as much as that is possible. So I ask the owner, is it an active or a passive process? Kind of, I want them to explain and maybe even show me what the animal is doing. I ask also about, of course, what is being thrown out, food, when after feeding, does it look digested? Is it froth? What kind of color has the froth? Are there prodromal signs such as nausea and licking its mouth and walking around in circles, and it will soon vomit? So the differentiation between vomiting and regurgitation, as much as it's possible, it's not always possible, will help us to kind of work up the dog, because regurgitation is a disease of the esophagus, while vomiting is a disease of basically everything else.
So that's actually a good takeaway already here in the beginning, because I tried to narrow down all my differentials, and knowing the difference between my patient today, this day is already going to narrow that quite a bit.
Well, I mean, if we know it's regurgitation, then as I said, we most likely take X-rays of the chest. But while if it's a vomiting, then chest X-ray, at least in the beginning, are not that important, unless we think it also has some aspiration pneumonia, which in vomiting are quite rare, while in regurgitation are quite common. So yes, I think it is important that we differentiate those two as much as possible. So, for example, a yellowish bile colored or whatever material being thrown out, whether that's with food or just froth, really points us towards vomiting. If it's a very whitish froth, like beaten egg white, that could point us towards regurgitation. That's basically the only real things that help us differentiate.
So I would like to test something I do on you, and I basically take every chance I can get to do a bit of acting, and I realize not everybody is like that, but I try to act out the two different things in the consultation room. If the vibes in the room is for it, I try to tell the owner that a vomiting dog is sort of working its way up to it, like it works the abdominal muscles like before it comes, and the regurgitation is it sort of surprises the dogs that just spit out what is down there. Is that sort of maybe a good idea, or is that off the mark?
I think it's a very good idea, unless the owner already. I don't want to pinpoint the owner to something. So I think it's important to what we call open questions, that they can really. It's not a yes/no question, but it's an open question, meaning that they can explain more in detail. But if I don't get I don't really differentiate by what I have asked, then exactly what you said is also what I'm doing, including making these weird vomiting or retching sounds. I think is really helpful. Or I ask the owners, is there anything before the vomiting happens? And sometimes they tell me.
Yeah. Good. So anything else in the history before we go on to the physical examination?
Well, of course, you take as good a history as possible. In internal medicine, we always say that between 70 and 80% of the diagnosis is history. So you ask about if the dog could have eaten something bad, where it gets its things, toxicities are important. You ask about all the drugs that the animal is receiving and has been receiving. You ask about the normal diet that the animal is getting, if it has had a diet change. Then, of course, you ask about the other things such as normal drinking, abnormal drinking. What is the feces looking like? Is there diarrhea, lethargy things? Has the animal been somewhere outside of Denmark? Just of course, you definitely ask about the deworming, anti-parasitic drugs. I also ask normally what kind of drugs it has received, and if the dose kind of was correct for that dog, because it could be a parasitism that causes vomiting. Of course, that's more likely to cause diarrhea, but it can cause vomiting. I also ask about the vaccination status. If it's not a client that comes to me routinely, and I would know, I ask about if other dogs in the household, in the vicinity, have had some vomiting. So I think as I mentioned, history taking is extremely important. And of course, you can do that simultaneously. While you take the history, you start with your physical exam.
Do you feel like, this is more maybe a philosophical question, but do you feel like the owners are giving you the correct information, or I'm guessing what it's at my clinic, I sometimes find that I'm not able to express what I want them to answer clear enough, and the owners sometimes are guessing what I want to hear, and I get the sense they are maybe making stuff up in order, or maybe not just completely random lies, but are trying to make the history fit with what I'm asking. So it's a challenge, I think, to
It
to
is a
get all the
challenge.
necessary information.
It is a challenge, and you're absolutely right. It's an art to do a good history, and when you have a young veterinarian working with you, they ask some questions and then come to you and explain. Then you go in and ask the same questions, and the owner answers something completely different, and you kind of wonder, why is it not what has been asked before? So owners don't really make up their mind, but they say what comes to mind first. And then if you ask the same question later again, suddenly they realized, well, maybe the first time it was not correct, so they answer a second time. And if I think it's an important question, I do ask it the same thing in another way again. And I try to avoid asking two things at the same time. So how often is it vomiting, and is there blood in it? So I ask, how often is it happening? And then the second time, is it blood in it? Yes or no? So the owners can only answer one thing at a time, and I also interrupt them when they go into a wrong direction that I think is not relevant for the case at this time.
Yeah. So what I'm experiencing is that sometimes I will try to ask very open-ended question. I will ask, "Can you please tell me what the vomit looks like?" And they will, yeah, well, it's basically just food. And I ask, just food? Yeah, just food. So you haven't seen blood in it? Yeah, there's blood as well also. So not just food. No, it's blood and mucus and food. Okay, but that wasn't what you told me. So sometimes I feel like I really have to be patient.
I completely agree. That's why, personally, I think it's very good to start with an open question, when they can basically say what they want. And afterwards, I think we should, I like to stop that. And I really like to go with closed questions, yes and no questions. So I say, blood, yes or no? Froth, yes or no? Is the froth whitish? Yes or no? Is it pinkish? Is it yellowish? Is it greenish? So I ask all these different things. Is there diarrhea? Yes or no? Has it been vaccinated? Yes and no? Have you gone abroad? Yes and no? Because I think it's much easier that you come to a true answer than when you give them open questions all the time.
Yeah. Good. So, but it is important to spend a bit of time on this, and you, as a vet, make your life a bit easier going forward if you have a thorough history, is what I'm hearing you say.
I think it's as I said, I think it's the most important part in internal medicine. We know in human internal medicine that the diagnosis is made 90% by the history taking. That's why so many human doctors never ever touch you, because after 90% they know what will be your problem. They try to treat it, and if it doesn't get better, then they do hopefully a physical exam. For us, it's still about 70% of a very good history taking that you can pinpoint where it's going. Also with vomiting. So I really, really think history taking is an art and is extremely important. And as I mentioned, you don't have to sit down all the time. You can do it while you do a physical exam at the same time. Of course, not while you do your auscultation of the chest, but when you do a abdominal palpation, you just take more time while you ask questions.
Yeah. So let's move on to the physical examination then. You mentioned something about mucosal membranes and palpating the abdomen. And when I'm in a hurry, I have to be honest, that's basically the physical examination that dog gets. But I know I can do quite a bit better. And we maybe are talking about more challenging cases here. So is there anything in particular that you are focusing on in the physical examination?
I think the most important part in the beginning really is to find out, when we're talking about vomiting, is the animal hypovolemic or dehydrated? Because does it need fluid or not? If it's an acute case, I think that's the first thing you want to know. So you need to do mucous membranes, capillary refill time, palpate the pulse, the frequency and the quality of the pulse, do a skin tenting, and with this you already have a lot. Then of course, looking at if the animal is lethargic, mild, moderate, whatever, you can do that very quickly. You don't need a lot. Yes, auscultation, we do that. But when you do, when I have the dog on the table, I immediately put my hands to the femoral pulse. So I already know, is it bradycardic? Is it normal? Is it tachycardic? The same with the cat. Is it a strong pulse? Is it the weak pulse? I get a lot out of that from the beginning. And with the mucous membranes together, I do get a lot. And then with a vomiting animal, of course, it's abdominal palpation. Be very thorough. Start. I think you should always do the same way. Either you start cranially and go caudally, or you start caudally and go cranially, or dorsally to ventrally. It's entirely up to you. But you should be in always the same way. I think I read a lot that the animal has a tense abdomen and you can't really palpate. And I think that's really mostly because you don't take enough time, or you have very cold hands. But that's why I say, do your history taking while the animal is standing. You stand behind the animal, and you just very, very calmly palpate the abdomen. In the end, you should be able to touch your own fingers. In cats, that should be very easy. In small dogs, that should be very easy. I mean, we all know if you have a Rottweiler that is 60 or 65 kilos, it probably will not be possible. And you don't even want to put the dog on the table that heavy. But in a lot of dogs, you should be able to find out, is there, what's is the bladder full? Can I palpate the intestines? And let's face it, a foreign body should always be palpable unless it really, really is very painful.
So I sometimes find that if I just place my hands and just squeeze in, most dogs will relax a bit. So if they are in just discomfort or maybe in pain, they will of course tense up the second you touch them. But if you move forward slowly, you will get more out of it.
I agree. Be slow in the beginning. Pet the dog a little bit and talk to the dog and talk to the owners, and slowly, slowly palpate. You get a lot more out than when the dog is vomiting or has diarrhea. You put it on the table and immediately palpate without doing anything else. Then you often get less out than when you start slow and then palpate.
Yeah. I'd like to return back to the body and the body, but you talked about the femoral pulse. So that's the inside of the hind leg, of course, but that's the easiest one, or is that just the one you prefer, or?
I think both. I personally, I think it's the easiest and the one I prefer because I get the most information from.
Yeah. Palpate that while you're listening with the stethoscope, or you just count the pulse there, or do you do anything special? Is what I'm asking.
To be honest, I don't always count the pulse because with time, when you're old enough, you kind of get the feeling if it's normal or not. If I'm not sure, then of course I count. But otherwise, if it feels like, oh, that's a normal pulse for that size breed or that cat, then I normally do not count. But I really the pulse, for me, the pulse quality is more important than the pulse quantity.
Can you talk more about that?
The pulse quality means that you feel, is it a strong pulse? Is it a weak pulse? Is it a normal pulse? And of course, you will. Veterinarians who've been in the job for a long time know that you get a feel for that. If you're a young student, well, it just takes some time, and the more you palpate pulses, the more you will get information out of it. That's why I think it is so important that also in a dog that comes in with no problem vaccinating, just briefly palpate the pulse, that you get the feel what is normal in that size dog with that amount of fat. If it's long hair, short hair, same for cats. Just do that over and over and over until you really, that's a very important part of your physical exam.
And then you said that most foreign bodies should be palpable.
I think so, yes. Now, if it's very painful, then it's not possible. But most foreign bodies, I'm not talking about foreign bodies in the stomach, but I'm talking about foreign bodies in the intestine, which of course can also cause vomiting. Most of those are palpable. And then when you find this kind of mass-like lesion, if you press hard, then they really have some pain, while a mass from a tumor in general doesn't cause pain. So once you get more used to it, then foreign bodies in the intestines should be now I'm not talking about a linear foreign body, that's something different, but a toy, a stone, whatever it is, should be palpable, not in the stomach. In the stomach often is not palpable, I think, in cats sometimes, but otherwise especially big chested dogs, the abdomen is not palpable, the stomach is not palpable.
How about organs, pancreas, liver, or that sort?
Liver is basically never palpable unless it's really, really big. I mean, if you have a hepatomegaly, then you can. Pancreas, the only thing that you can palpate, of course, if there is pain, you can't palpate the pancreas. The kidneys, I think, are palpable in almost all cats. In dogs, sometimes. The bladder is always palpable if it's not completely empty. And that's basically it.
Would you do rectal examination also for the vomiting dog specifically?
Good for asking. Personally, I think any dog that has a gastrointestinal disease should have a rectal exam, or any patient, not only dogs, because I think in a lot of cats you can do a rectal exam. Yes, I agree. You can't do it in every cat. And in cats with vomiting, I wouldn't do it all the time. I do it only if I have a suspicion, if the cat has some vomiting plus maybe some problem with defecation. But in dogs, I think a rectal exam should be part of your physical exam in a animal where you have GI disease.
I'm asking because I find that sometimes the tells me that the last time the feces that was normal, and then the dog is vomiting, and I do a rectal exam, I get some very nasty diarrhea, smelly stuff out. And okay, so maybe it was normal yesterday, but the feces that's coming next time is diarrhea. So that sort of takes more towards an infection or dietary upset more than a foreign body, I guess.
Absolutely, I agree. And that's why you should do a rectal exam in almost all dogs. I mean, not talking about a completely healthy dog that has been vomiting once or twice and otherwise is healthy. But if an animal shows more than 2-3 times vomiting over 24 hours, and has any other problems on your history or physical exam, then I think a rectal exam should be part of it.
Sometimes sniff the thermometer, and people are looking at me funny when I do that, but there is some information in that as well. Anything before we leave the physical examination, because now we are going into paraclinics.
No, I think once you've done what I've just mentioned, as I said, you also should. I'm not a person to take the temperature in every patient, but if I have a patient that is unhealthy, then I think it's part of it. I definitely want to know if it's hypo or hyperthermic. So temperature is important, but not overly important. The same as I mentioned for the pulse. Is the pulse quick or slow? So a bradycardia will be more important than a tachycardia, because a bradycardia in a vomiting dog might point towards a hypoadrenocorticism. If you have a dog that has been vomiting for the last 3-4 months intermittently, and now it's getting worse and has a heart rate of 54 or something, then that really should make you suspicion.
So I think my sense is that I dive into blood work next thing, and I guess I too often dive into that too quickly, because we have already quite a lot of more information about the dog now than I have with quite a lot of my patients, if we've done what you told us so far. But jumping to the blood work, is that a logical next step, do you think, or is there something else that you would try first?
I think there are two options now. One of the options is that you do more diagnostic investigation, and the other option is that you do a therapeutic trial. And it all depends of how sick the animal is and how bad the vomiting is and so on. So if you have a dog that is quite healthy or healthy otherwise and is only vomiting and has been vomiting, it comes on a Saturday during the emergency hour, and you has been vomiting since Friday evening, and the owner is unhappy because had to clean the carpet twice. You do your physical exam, everything is completely normal, you don't find anything abnormal, it has only been vomited twice, then I don't have a problem in that dog to do a therapeutic trial and say, well, why don't we try with some antiemetics and maybe a dietary change and see how it's going? Because let's face it, probably about 70-80% of these patients only have somewhat we call dietary indiscretion, or we call it acute gastritis, whatever that means, and they will be better afterwards. And they don't need any blood work. If, however, the animal has been vomiting for a week or even 5 days, and it's getting worse and it doesn't stop, or the animal is shows some lethargy, or the animal has tachycardia or abnormal temperature, then I think blood work is not only needed, but then I think it's mandatory that you do some blood work to find out what's ongoing. So for me, it really depends on your history and physical exam.
Do you use anything else for the dog on Saturday that I would like to send home? Some antibiotics and some dietary changes. We have something that I forget the content of it, but it's something that you swallow when you have also gastric ulcer as humans, and we sometimes do that, or we use acid inhibitors and quite a lot of other things. But you
Okay.
only mentioned two. Is that
okay? Let's start with the healthy dog. Huh? Healthy dog that you only treat on a Saturday evening, or it could be any day. It doesn't really matter. Huh? In these dogs, I would give a antiemetic drug, and we can talk more about the antiemetic drugs, plus potentially a dietary change the dog to a easy digestible diet. It's nice because you can sell some diet, whatever company you like, and you have. They all have some diet, some intestinal diet, or for 3-4 days, 2-3 days, you can ask them to cook. Chicken and rice is what we always did. Don't do that for a long time, but easy digestible diet for 2-3 days. Chicken and rice is always works. Huh? I think all the other drugs. No, what you could also do if you really want to, you could give it some kind of probiotic. That might give a change to its microbiome, but oftentimes that's not really needed in a vomiting dog. So I think mostly it's a antiemetic drug and a dietary change, and that's it. All the drugs that you mentioned, gastric protective drugs, including proton pump inhibitors, omeprazole, pantoprazole, including H2 blockers, cimetidine, ranitidine, all of them are really not needed. And I think you shouldn't give them because they do more, in most cases, they do more harm than good. Let's start with the H2 blockers, the cimetidine, ranitidine. They actually have basically no effect in dogs whatsoever. So you can skip those and throw them out of your pharmacy because they really don't do anything. If you really want to use a gastric protective drug, and that's if you have an animal that has been ongoing vomiting for a while and has bloody vomiting, then please go ahead and use a omeprazole and pantoprazole, but then you must use it at least for a week or longer, maybe 2 weeks or 3 weeks, because they don't work in the very beginning. It takes 2-3 days until they have full effect. You definitely need to give it twice daily, both in dogs and cats at the 1 milligram per kilogram. And as I said, you need to give it for a prolonged period of time, not more than probably about 2-3 weeks, because then you may have again some negative side effects. But most of these drugs are not needed in vomiting dogs because they have absolutely no antiemetic effect, as some people think. And most animals with vomiting do not have gastric ulcers. Gastric ulcers are extremely rare. And for example, people always talk about Helicobacter. Helicobacter in dogs and cats are of completely no consequence. If you treat them, wait 4 months and they will have them again. So I did my PhD long time ago on Helicobacter, and at that time I probably knew every single publication, and I can definitely say they are of no clinical consequence. So you don't need to treat Helicobacter with triple or quadruple therapy with bismuth and with proton pump inhibitors and antiemetics and so on. They really are of no consequence. And dogs and cats do not have the same Helicobacter as humans. So it's also not a zoonotic problem, because some humans say, oh, I've been diagnosed with Helicobacter pylori and my dog is vomiting. Maybe it has the same problem. No, it does not, because they have completely different Helicobacter species. Dogs and cats have Helicobacter bisozeroni, Helicobacter heilmanni, Helicobacter felis, whatever they're called. And humans have Helicobacter pylori, and it's almost never a switch from one to the other one in species-wise.
So I will ask you this question again when we get to the more severe case, but focusing on this case that we want to send home on the same day, do you use steroids and antibiotics?
Thanks for asking. The answer is clearly no, for both no. Definitely a no. Steroids, I use steroids really rarely for animals that need steroids. And if you give a steroid in a patient like that, and in the end it has other disease, it's often very difficult to make a diagnosis. So you should avoid it as much as possible. And antibiotics is even a more strong no. I mean, you're a Scandinavian country and you have much stricter antibiotic rules than we have in Germany. I'm a complete abolisher of antibiotics as much as I can. So gastrointestinal diseases and antibiotics together have absolutely never or hardly ever anything to do. I'm not talking about this acute parvo case that is neutropenic and everything. Yes, of course it needs an antibiotic, but all these acute cases that you have otherwise, absolutely no antibiotic, no metronidazole and nothing else.
You seem, people can't see your face, but I can, and you seem quite adamant that this is your case.
Yes, it is. Yes,
yeah.
Yes.
Okay. Good enough. All right.
Let's talk about the antiemetics at that time. Okay.
Yeah.
So antiemetics for the easy to treat dogs. I mean, you should know a little bit about the what antiemetics are licensed, and in dogs and in cats, and I'm pretty sure that's the same in Denmark as it is all over Europe. We have two licensed drugs. One of them is meropitant, and the other one is metoclopramide. Meropitant. You have another one as well?
Oh, that's the two we have.
Okay, meropitant is a neurokinin receptor antagonist, so it works on the neurokinin receptors, and there are neurokinin receptors in the periphery and centrally located. Centrally, if we talk about the whole vomiting reflex and everything, there is a vomiting center in the brainstem, and it needs to be innervated. But when an animal vomits, it can either have central vomiting or peripheral vomiting. Central vomiting normally comes from a reflex coming from the chemoreceptor trigger zone where there is no blood-brain barrier. So if you have some toxins, some drugs, some endogenous emetogenic substances such as like ammonia, such like some cytokines, etc., they can all cause various forms of vomiting. So the meropitant is probably your most potent antiemetic drug that you have available. And when I have an animal that comes in with acute vomiting, I have no problem giving it one injection of meropitant, but don't give a more meropitant at home, because if it continues vomiting after 24 hours, then it needs to come back and you need to do more diagnostic investigations. But it also is an anti-nausea drug, so it really works very well. The animal feels better, stops the vomiting, and then you already have the novel diet in there with which is easy digestible. So all combined is very, very helpful. And it also, as I mentioned, it works central vomiting. So if the animal has had some whatever, eaten some bad stuff, and there are some toxins, and you can't really get rid of those, then it will also work. That's for the dog. That's for the dog and the cat. In the dog, you can also use metoclopramide. Cats have very few D2 receptors. Metoclopramide is a D2 receptor antagonist, so it works on the mostly on the vomiting center and not for peripheral vomiting. So in cats, meropitant is much better than metoclopramide. And while we talk about the drugs, I think it's also important now, not for the easy to treat patients, but for the more sick patient, when eventually you have a patient that has kidney or liver disease and that results in vomiting, then don't forget that meropitant is mainly metabolized by the liver. Serenia, Prevomax, or whatever you use can be easily given in animals with kidney disease, because they are not excreted via the kidney. And metoclopramide, on the other hand, is almost all excreted by the kidney and is hardly metabolized by the liver. So metoclopramide is really the drug that you should more use if you have an animal with liver disease, because it's not metabolized by the liver.
So I was actually going to move forward with the acute case, but maybe we should interject another midway case here before we do that. Because let's say this Saturday dog has gone home, everything was fine for some time, and then it returns maybe 2 or 3 times to the clinic over the following period. It's still not a sick dog. It's mostly happy and eats what it gets, but the vomiting seems to be recurring, or maybe get a chronic feel to it?
If that's the case, you definitely cannot send it home again with serenia or metoclopramide and a diet. Then you need to do further workup, like you would have in a sick dog. So I would say you can use it once, maybe twice, but after that, you need to do more diagnostic investigations, because it could be a gastric foreign body and it will not go away. It could be any problem that is happening, kidney disease, liver disease, you name it. You need to know more about that patient. So once, maybe twice, give it a antiemetic drug, and then do more diagnostic investigation.
Where do you start that? Is that imaging first, or blood work first, or something third?
It kind of depends how much the owner is willing to pay. Ideally, you probably do blood work and ultrasound if you have and can do it. If your physical exam was really completely normal, your abdominal palpation is completely normal, I definitely would more go to blood work. If on your physical exam you really think, I'm not absolutely 100%, then abdominal ultrasound, I think, is a very good tool at that stage. X-rays of the abdomen in general are not that helpful in a vomiting dog, unless you really already feel something abnormal on your physical exam. Then maybe if you talk about a intussusception, but again, intussusception is like a gastric, like an intestinal foreign body. Most often you can palpate an intussusception, and the animal is not healthy. The animal will be sick when he comes in, and that's a patient that you should not give a antiemetic drug and send home.
So I think we should dive into all of these three. So I can take X-rays, but I'm usually have to ask a colleague interpreting them. Ultrasound, I have a very skilled colleague that can do that. I don't do them well enough myself. So that both of those require some help from an expert, I would guess. But I'm also hearing you say is that I cannot just put it on the example and expect the diagnosis to be present in the recordings.
No, you I mean, everybody can take an X-ray. Huh? I don't know how it's legal in Denmark. In Germany, the nurses most commonly take the X-rays, because we do other things as veterinarians at that time, which I think is the way it should be. So everybody can take an X-ray, and what the advantage of X-ray is, of course, that even if you are not capable of interpret everything, you can show that X-ray at the later time, and maybe even at 8 in the evening, 10 in the evening, to your colleague, because he may have access to your patient management system online and look at it, or you send him a picture of the X-ray via WhatsApp or whatever. Look, do you think it is an intussusception? So X-rays for that are helpful, and it's also helpful for if the owner later wants to sue you, that you can show, well, I did do an X-ray, and we have more and more of owners going in that direction. So X-rays for that are helpful. Ultrasound, well, I mean, what ultrasound really is helpful for in the emergency setting is if there is a foreign body, you probably would be able to see it, even if you're not good at it. And maybe you would see an intussusception. I'm sure you wouldn't be able to see a very mild thickening of the intestinal mucosa, but that does not need to happen on a Saturday night. But free fluid in the abdomen is something a lot of people are able to find. You don't need to be able to say, well, this liver is completely normal or a little bit hyperechoic or hypoechoic, but masses, the things that are kind of, what shall I say, plain obvious, can be done also in the evening. And I'm not a good ultrasonographer. Huh? I ask somebody else for the nice and specific things, but I can find masses, and I can find intussusception, I can find free fluid, and that gives me some confidence what to do next. But a lot of these patients have some clinical abnormalities, like I mentioned, so you know better. And if you really think in a patient, if you do not have a surgical capability and you feel a mass and it's really vomiting and you think it's an intussusception or a foreign body, then that might be a case that you don't do ultrasound, but you refer immediately after your physical exam.
So both of these would, in my hands, be mostly rule out procedures, and I have to be careful not to sell them as something I'll just take a neck and see what's in there, and I'll give you the result afterwards. But I would try and rule out free fluid, pyrethrum, and an obvious foreign body, and then so we can focus maybe on other things, and that's in the communication with the owner as well.
I completely agree. I mean, a pyometra might cause vomiting and might be a closed pyometra, and the owner doesn't really realize that the dog is also PUPD because they think, oh, it's drinking more because it's vomiting. So I completely agree with what you said. It's the way how you sell it, and never say, oh, I'm sorry, I didn't find anything abnormal, but say, oh, it's fantastic, we didn't find anything abnormal in that diagnostic test. That doesn't mean there's nothing abnormal, but it means that currently it's not severe enough that we can see it, and we need to do other tests. But it's always say, oh, it's fantastic that nothing abnormal was found, and not, oh, I'm sorry that nothing abnormal was found.
So let's play with the idea that the dog has insurance and we can run the blood work that we need. Not everything, of course, because we only want to run what is needed. But what especially would you require us to run, or you for in the lab?
Okay. Even without insurance, doesn't really matter. I personally believe that it's a good idea in the beginning to be a little bit more broad than just two single parameters. So depending on what system you have in your clinic, your practice, I think you should always we're talking now in a more sick dog, maybe dehydrated, whatever it is. I think it's very worthwhile to do a hematology. And I think you should do hematology always in-house, irrespective, if you have a machine, of course, irrespective whether that's a long-standing or short-standing abnormality, because submitting it to a centralized lab often causes some changes in the red and white blood cells. So personally, I think hematology should be done in-house. And you should, of course, look at your results and see if the machine puts up some flags depending on what they are. If everything is completely normal on your hematology and there are no flags, then that tells you, well, most likely everything is normal. If you find abnormalities on your hematology results, then it kind of depends on what you find. If there is a erythrocytosis, in a vomiting dog, then it's most likely dehydrated and you need to give it, or hypovolemic and you need to give it some fluids. And then you need to look at other results, what kind of fluids. If you look at your white blood cells, then you look at all the white blood cell numbers, are the leukocytes normal, or neutrophils, eosinophils, and so on, and see what's there. And if there are a lot of, or if there are some flags and you're not certain, then depending on the machine you have, you should go and look at the scatter plots. A lot of machines actually do show scatter plots, and I'm surprised at how few veterinarians ever go and look at them. We can't talk about the scatter plots here because it will be another 2 hours.
But
but
it's visual as well.
And it's visual.
I do know that the IDEX laboratories is the one that we use where I work, and they have a 7-minute video through the basics. So
absolutely.
So it's not all that cumbersome.
But do look at it. That's important, or do a blood smear. So that's the hematology. And in terms of biochemistry, I think it's important that you do run, especially in dogs, electrolytes, but also in cats, because you want to know, you need to replace potassium, sodium, and how much is it lower or is it elevated. And in terms of biochemistry, the other results, it's nice to have some kidney values, urea, creatinine, phosphorus. It's nice to have some liver values, glucose, to have bilirubin, to have 1-2 liver enzymes. It's nice to have maybe, well, cholesterol, triglyceride is not that important. If we talk about pancreas, pancreatitis, which can result in acute vomiting, I think it's extremely difficult, and it's probably the most overdiagnosed abdominal disease ever, because most lipase and amylase tests done in-house have a very low sensitivity and specificity. So you overdiagnose and underdiagnose. And ultrasound is also not easy. So making a diagnosis of pancreatitis is difficult. You ask 3 clinicians with the same with the same results, and you get 3 different results. Yes, maybe no. In the end of the day, I don't think it really makes that much difference for the patient. It's more about communication, because hopefully you will treat the patient the same way anyway. These patients need fluid, analgesics, and antiemetics, and that's basically it.
Yeah. How about the CRP, inflammation number?
CRP is, if you have an animal for vomiting, I don't think it's a very helpful test. It has a lot of false positives. It has sometimes false negatives. For pancreatitis, it's not that helpful either. False positives and false negatives. There are a lot of other diseases where it doesn't really help. So in my hands, CRP for a vomiting patient is not high on my list.
And the specific lipase?
No, the CPL, CPL and FPL. There was just very recently a publication came out of FPL for cats. Very nice publication, which showed it had a quite poor specificity and also not an excellent sensitivity, meaning that it is heavily overdiagnosed based on FPL. And even if there is pancreatitis, it is sometimes underdiagnosed. So if it gives you peace of mind and you sleep better, then please do it. But I think it's not enough. For me, ultrasound, even though I'm not a good ultrasonographer, I think ultrasound is a better tool to diagnose pancreatitis, both in dogs and cats. But if you either do not have a machine or you feel very you feel you're not really good at it, then it might give you some information. But don't put all your money on F or CPL.
So we into pancreas and liver and kidney diseases podcast in themselves. So I'd like to focus on the vomiting dog here. I think maybe a kidney disease is somewhat obvious, I would expect. Or can it be mild and still cause vomiting, and then you would have to run an SDMA, or you have to do urinalysis, or be more thorough in order to pick up a kidney case? Or would you expect it to be quite obvious when the dog?
If we have vomiting in a case, then almost all patients that have, I mean, we classify kidney disease if it's chronic according to the IRIS guidelines, and there are also IRIS guidelines for the acute kidney injury. I would not expect an animal in an IRIS stage 1 to actually show vomiting. IRIS stage 1 cases have other clinical signs like PUPD, and or they did have acute kidney injury and now they're in stage 1. So in general, if urea creatinine is normal in a well-muscled dog and has no other thing, then I would say kidney injury, kidney disease is pretty much ruled out if the animal has as major problem vomiting.
Yeah. And how about the liver as well?
the liver, definitely look at every value and look at the age. I mean, you have sometimes some chronic liver disease, and then we have sometimes some animals with portosystemic shunts where they have almost no liver enzyme abnormalities, but they may have a low MCV on your hematology, they may have a low urea on your biochemistry, maybe just a touch low glucose on your biochemistry. So liver is more difficult, and not all of them are plain icteric and have marked hyperbilirubinemia. So if you have some values on there that are potentially pointing towards a liver shunt, then of course go ahead and do some bile acids. More importantly, the postprandial bile acid. If the animal is eating 2 hours, maybe both preprandial and postprandial. And if you have the option in your clinic to do ammonia, it's more difficult to do ammonia testing, but if you have the option, then look at that. So liver is more difficult, and that's something that might. I don't think it's often needed in an acute case. It's more something for a chronic vomiting case.
I have a couple of cases I'd like to try on you as well, but before we get to that, let's say that most of this has been done that we talked about so far, and most of it is normal or somewhat normal, and you get a case referred. What's the high end stuff? Do you do a laparoscopy an explorative laparoscopy? Is that the correct word in English? Or endoscopy? Or what are some advanced options? CT scans or?
Okay. Now, if you have a case that comes in with chronic vomiting or even vomiting for 2-3 days and is clinically sick, then I would do a full hematology and a full biochemistry. In the chronic cases, I definitely would do a cobalamin concentration to see if that's normal or abnormal, more so for later treatment. In a dog, I definitely would also do either a basal cortisol concentration or a ACTH stimulation test. In a elderly cat, more than 7 years old, I definitely would also do a T4 value to see where that is, because hyperthyroidism in cats can result in vomiting. If that is all still completely normal, then I would do a abdominal ultrasound, a complete abdominal ultrasound, and see where we're standing, and hopefully find something there abnormal. I'd hope that the animal had been dewormed, because I don't think it's worthwhile to do endoscopy without prior deworming, even though if a fecal analysis is negative, because only a positive fecal result is proof, and finding tapeworms is almost impossible. Only 20% of all the cases with tapeworms will have a positive result. Roundworms with 3 fecal samples you may find, but still, if it's negative, it could still be tapeworms. So I would deworm the patient with some fenbendazole, with a praziquantel to be certain in a chronic case. Doing endoscopy of the intestinal tract is really kind of the last resort. And in dogs, yes, sometimes it's needed. Sometimes you find something abnormal that you don't find on ultrasound. In cats, if you suspect that the cat has a IBD, then it's more likely that you will find it on a full thickness biopsy, not on an endoscopic biopsy, because it's mainly in the muscular layer. So in cats, I'd be more likely, if I have a suspicion of an IBD, to do a laparotomy and a full thickness biopsy. But in most of these cases, you would have first on your physical exam some thickened intestinal tract. Then you most likely will have some abnormalities on your ultrasound. So often with your prior diagnostic testing, you hopefully would get some results. And CT, yeah, of course you can do CT, but that's really the kind of the last resort before. That if I do CT, then I generally do CT not only of the abdomen, because then I also do CT of the thorax, because it goes so quick.
Yeah, good enough. So I want to be mindful of your time, and we only have a couple of minutes left. And when we talked prior to this interview, I joked on that I wanted to test you on your knowledge. But what I'm mostly to do, of course, is that I would like your thought process on how you approach these cases. And I have two here that we could maybe go together, and both of them are made adjustments to them so they're easy to talk about. But they are both cases I've seen. So the first one is Bobber. It's a name from a children's show here in Denmark. It's a 3-year neutered male Labrador Retriever, and he's presented with an set of vomiting for about 24 hours, and the owner has a show in the weekend, or he needs to do something. I forget the name in English. Hunting training and she has a show in the weekend, and she wants Bubba to be well for that, and she asked me to do everything in my powers to help him get better soon. So aside from a mild dehydration and maybe a bit of slower pace, he's not completely lethargic, but he's slower. But for a Labrador Retriever, he's running around in the consultation room. He's not eating quite a lot as he used to, but he is eating, and he can keep most of what he gets down. So,
okay. I mean, if it's...
Yep.
I mean, it could have anything. It could have a hypoadrenocorticism because it is a young Labrador. It's more in females than in males with a GI disease. It could be a dietary problem. It could be a well, from the shunt I mentioned, also Labradors have sometimes kidney disease. It could be basically anything. It could also be just a very mild dietary indiscretion that has been ongoing for 24 hours. So if that's all that I have at that stage, I probably would put that dog only if I'm the normal vet and not the referral vet because the dog has been referred to me, if I'm the primary vet, then I probably will put that dog on a easy digestible diet. I probably would give him an antiemetic if everything on physical exam is completely normal otherwise, and see how it goes over the next 24 hours. Even knowing that maybe it has something more. And I would tell the owner, we try to treat the most likely, the treatable, and if it's not that, then when you come in again in 24 hours and it's not better, then we would do some blood work.
Yeah, that was actually also what I wanted to do. But the owner here, she wanted maybe we went a little bit overboard, so we run blood samples as well, and they were normal. Just the hematology and the biochemistry. We didn't run anything else on that day, and we had it in the clinic for a couple of hours too, and we managed to get it about half a liter of mine. So and the dog felt fine. Actually, it was more difficult to keep the dog calm while we gave the intravenous fluids than anything else. But when
if you
came back and
if I might interrupt here, if you think, I mean, it's a Labrador. The Labrador is probably about male Labrador 3 is probably about 30 kilos, huh? And if you said clinically he was probably a little bit dehydrated, and we can only guesstimate dehydration when it's more than 5%. So 5% of 30 kilos, 1% is, let me think, 10% is 3 kilos, so 1.5 kilos. So it would need 1.5 liters of fluid. So half a liter is only about a third of you actually would want to give it the dog over the next probably about 6 hours. So you need to, if the dog comes in the morning and you want to send it home in the afternoon, you should give it quite quick fluid. You want to give with the next 6 hours about 1.5 liter of fluids IV. Use a isotonic solution, lactated drink, or whatever you have available at that stage.
Yeah. So the case was that when she came back and picked up the dog, she has been home. The owner has been home Googling, and she asked me if the sausages she's been giving for the last 2 or 3 days could maybe have to do with it. So what I forgot to ask in the history is that I've been doing extra training the last couple of days because of the show, the fall weekend, and she's been giving some very nice treats with some sausages and a lot of different stuff that the dog normally doesn't get. So exercise and sausages became the main diagnosis in this case.
Absolutely possible. I mean, as I said, you don't really need to do diagnostic investigation on the first day if you don't want to, or if the owner doesn't want to. Give it fluids, maybe an antiemetic drug, and send it home, and be certain that it is properly dewormed.
Yeah. So the next case is Shadow, the 4-year-old unspayed female poodle mix of Labrador and red dog. I don't remember. Shadow has been experiencing chronic and intermittent vomiting and lethargy and weight loss over a couple of months, a few months, 2 or 3, as I remember. The owner also reports occasional episodes of diarrhea. On examination, the dog is quiet, but I don't find anything really concerning. It is a thin dog, but being a poodle and a Labrador, I didn't put too much weight on that, but it is a very slim dog. So we elected for comprehensive blood work with electrocytes, and the potassium was slightly increased. The sodium was in the low range of normal. Blood chemistry seemed normal, and the hematology was also mostly normal, with the hematocrits in the lower range, together with lower numbers of red blood cells.
Okay, I mean, with it's a poodle, it's a female poodle. I definitely would a non-spayed. I definitely would ask also about when was the last heat. So I'm certain that we don't miss anything from pyometra. Then in your physical exam, you said there was nothing abnormal. I would definitely also look at the vulva to be certain. I do that always in female unspayed dogs, especially if they had heat over the last month, something like that. With the hyperkalemia, I mean, hypocortisolism would be somewhere on my differential list, because if it's vomiting all the time, you would rather expect a hypokalemia. So I would look at my blood work again. See, hypoadrenocorticism often has anemia. Are the red blood cells on the low end? A lot of hypoadrenocorticoid dogs have some form of lymphocytosis, or maybe normal lymphocytes. So I would look at that, because if the animal is sick, then you would expect more lymphopenia. And I would look at my eosinophils on my blood, on my hematology, because if an animal is stressed due to disease, you would expect more eosinopenia. And if the eosinophils are normal or even elevated, then you would have more point towards hypoadrenocorticism. So in a case, and poodles are more likely to have Addison's disease. With everything you mentioned, I would definitely advise to give it fluids, do either a basal cortisol and measure endogenous ACTH. So, and then I can calculate my cortisol ACTH ratio. I like that. Or I would directly do an ACTH stimulation test, give it fluids, well, in that dog, maybe depending if it's referred, then I would do an ultrasound, because it's been ongoing now for quite a while. I would look at the adrenal size. I would look at the intestines. I mean, it could also be anything else. It could be a lymphocytic enteritis. It could be many, many different things. But those are the things that come first to mind.
Mm-hmm. So you have a plan already in your head. I can hear. So I actually the sodium levels were normal, but on the lower end, and I thought, yeah, well, the dog has been vomiting, and I luckily have a very skilled colleague in internal medicine, and she suggested an ACTH stimulation test. And it was positive for Addison's disease. So you are completely right on that. And the symptoms resolved with treatment. So there's there.
One thing you should never forget, if you do an ACTH stimulation test, you need to be certain that the dog did not receive any steroids. Even one injection of prednisolone given up to 4 weeks beforehand can cause a flatline ACTH stimulation test. If you give dexamethasone, it can be even longer, 6 weeks, 8 weeks. So we've had multiple times cases that had flatline ACTH stimulation tests where we said, oh, wow, another Addison's, which in the end was not the case, because if you go back to the history, you find out, oh, it did receive steroids. Another reason why you should not send animals with vomiting home on some steroids, even low doses, low dose, 0.5 milligram per kilogram prednisolone can flatline your ACTH stimulation test up to 4 weeks.
Yeah. So this one didn't get steroids, but it get antibiotics. So we're not completely perfect yet, but still, right. But the antibiotics didn't resolve the Addison's disease. So,
what a wonder.
Good, Reto. Thank you so much for your time. And we also went a little bit over. Oh, sorry for that. But thank you so much for sticking around. And hearing you talk about this has been such a blast, because I can really hear the enthusiasm in your voice, and hopefully that comes across to all our listeners as well. So just before we end here, if people would like to know more about you, or to Google you, or to read more about you, what's the best way to do that?
If you want to contact me, the easiest way is by email. So my email address is reto.nieger@ivcevidentia.de, DE standing for Germany, Deutschland. And if you put my name in Google, you find there's only one other Reto Nieger, and he is a guy from Switzerland who is making snowboards, and he is a lot younger than me. So if he looks like a 16-year-old guy, then it's me.
Okay, good enough. I will put everything in the show notes as well for this episode. So thank you very much.
You're welcome, and hopefully you all had a good time. Thanks for listening.
Husk, at du kan finde links og noter til dagens afsnit på sivp.dk, og så episodens nummer, for eksempel sivp.dk/1. Og føler du et behov for at udvide dine faglige færdigheder, uden at skulle tage en hel dag væk fra familien og fra klinikken, så har jeg nogle online kurser til dig. Du har måske hørt mig sige det før, men du kan få en hel måneds gratis adgang. Og det kan du få med en speciel kode, som jeg ikke deler noget andet sted end her i podcasten. Og det er fordi, at dig, der lytter til podcast, du er noget helt særligt. På sivp.dk/xyz får du 4 ugers gratis adgang til kurserne og protokollerne på hjemmesiden. Alle kurserne har specifikke læringsmål, så du ved præcist, hvad du får ud af den tid, du investerer i det. Du kan for eksempel lære at lave en regelret neurologisk undersøgelse og bruge det allerede næste gang, du er på klinikken. Du kan også lære at tolke blodprøver, og du kan lære at lave et godt finlåsaspirat og tolke det sikkert. Der er meget mere, men kig over på sivp.dk/xyz og tilmeld dig den gratis adgang, så kan du se, hvad du kan lære og bruge allerede næste gang, du er på klinikken. Udover alt det, så får du også adgang til et lukket online forum, hvor du trygt og sikkert kan dele alle dine i gåseøjne dumme spørgsmål. Dem er der selvfølgelig ikke nogen af. Men vi er sammen om at lære. Du skal ikke lære alene. Vi er sammen om at blive bedre. Og så ved jeg godt, at der er nogen, der er bekymret for at tilmelde sig et medlemskab. De er måske bange for ikke at få det brugt. Og jeg ved godt, at du som lytter til det her, jo går op i din faglige udvikling, for ellers havde du jo ikke lyttet til podcast. Men skulle du nu alligevel være bekymret for at glemme at melde dig fra, når din gratis måned udløber, så skriv lige til mig. Jeg har nemlig resultatgaranti, og det betyder, at hvis ikke du ser resultater i din hverdag, så skal du selvfølgelig ikke betale for noget for at have været på kursus hos mig. Se på sivp.dk/xyz for at tilmelde dig en gratis måned med det samme. Vi ses!